Hello. How is everyone? Hope you had a good night. Um, for those of you who are joining us today, I'm wondering if I should offer that opportunity for you to just introduce yourself. Mr. Raf, I'm looking at you. Just say hello to the group and tell us where you're from.
Yes, good morning. Good morning. Yes, my name is Ralph Muli. I work for Nairobi City County. I'm in the health sector. Thanks.
Thank you, Raf. You missed a lot. So as you interact with people, they'll let you know what we've been doing for the last 2 days. Oh yeah, sorry. My apologies.
Thank you. Good morning, everybody. My name's Nishad Patel. I am from the US and I also live in Kenya. And I'm involved a little bit with air quality around Mombasa area. Thank you.
Welcome. At least you have a colleague from Mombasa. So you'll connect during the day. Thank you so much. So today we would like to go into our training session. So we have three main goals for this. We are gonna introduce the key concepts of health impact assessment in a light way. We hope to equip most of you who are already gathering air quality data to start thinking of how you can merge that data with health data for analysis. And we're also looking for your feedback in terms of what do you need beyond, what we'll be able to cover today. We only have half a day, so we'll not go into too much detail, just to sort of elucidate your thinking towards, how can we now start moving into using air quality monitoring data that we have, with the health data that we collect to sort of start doing health impact assessments. So I will just introduce John, who will start us off, and he can take it from there. Welcome, John.
Okay, good. Thank you, Victor. And here's a first question for you. Am I going to say good morning or good night? It's actually now, where I live, it is almost 1 a.m. It's good morning. So we're up to good morning. So that's good. Now you're supposed to say good morning. I've learned that. Come on. Good morning. No, better. Come on. Ernie, that's good. We have to get you prepped for the workshop, because the first thing I'm going to give you is a warning. And you may be worried about what the warning is. Are you worried, Lynn, about the warning? Yeah, I'm warning you. And here's the warning. You must participate. Okay, so you have to participate, and because otherwise it won't be a workshop. So we're going to participate and talk about what you've done. Who's done a health impact assessment? Raise your hands if yes. Okay, so a few. How many of you have used burden of disease estimates, maybe from the global burden of disease or from the state of the global air that the Health Effects Institute prepares? Have used that in your work? Anybody used state of global air? Few. Okay. How many of you don't know what state of global air is? It's okay to say you don't know. Everybody knows the state of global air? Wait a minute. So, state of global air. Do you know state of global air? What it is? No. Okay, so you have to raise your hand. No. You didn't? Okay. Who else how many of you are not familiar with the state of global air? We talked a little bit about it at the start of the workshop. So it's a tool that is intended for you to use for burden estimates that relate to where you are. So we're going to go through the concepts, and we're going to talk about how we do these things. So here's what we want to do in about 3 hours. We're going to talk about estimating burden of disease, what it means. And we're going to talk about an important word that you have to remember called the counterfactual. Okay, we'll talk about what that means. We're going to talk about some of the tools for doing health impact assessment and how to use health impact assessment for decision making. Cardi is going to talk about experience in South Africa and making these estimates. We're going to talk about some of the uncertainties, what we don't know, how to communicate about these results, and we're going to hear some real examples, and I'm going to be helped by colleagues from the GeoHealth Hub, including Otieno, good morning, and also Abra. So, and anybody else who wants to participate. Lynn is working on a health impact assessment, burden assessment as well. So, and Alex? Yeah, okay. So everybody who has. So we've got a lot to do. And then that said, you can just stop anywhere along the way with questions. This is not going to be a formal presentation, but feel free to just raise your hand and say, I want to hear more about whatever it is. Okay, so feel free to do that. Now, just again, and sort of how this all comes in. I'm just going to talk about a few sort of real basic things. And I think I showed this the other day about what safety is. So what we're concerned about is the risks of outdoor air, indoor air, the risks of breathing. Okay, and if you think about it, everybody take a breath, a deep breath. Okay, and you took a breath. Your breath was probably, if it was deep, it was probably 3 liters. Okay, and how many liters of air do we breathe a day? 10,000 liters of air a day. Okay, and in that breath, does the air in this room seem clean? Yeah. So there's probably some particles here. Let's see. What is the concentration of particles probably in this room right now of PM 2.5? Is there any are there any particles in the air here? Yeah? So it's probably 5 to 10 micrograms per cubic meter of PM 2.5 right now in this room. And if there's, in a liter of air, at that level, there's probably several million particles. So that breath you just breathed in was a couple of million particles. And you take 12 breaths a minute, so maybe you get 24 million particles a minute times 60 minutes per hour times 24 hours a day times 365 times, how long do you want to live, Otieno? 70 years, 80 years? 120 years. So he's getting a lot of particles. So if you think about it, that's why we're worried about the risks, because the concentration may seem low, but by the time we breathe in all this stuff, then we're worried about what it might do. So in terms of making the air safe, we need to know what the risks are. And that's what a lot of epidemiology is about, of course, and that's what these burden estimates are about. And then this question of judging if the risks are acceptable is that's what we do as a society. That's what decision makers do. That's what regulations are about. The WHO air quality guidelines, the 5, is intended to be roughly the level at which we can't find a detectable adverse effect. So that came from putting the epidemiological studies together, looking at how the risks change as you go to lower and lower concentrations. And there was a point at which you couldn't detect effects anymore. Maybe that's in part because of the limitations of the study, but that's the idea, that you go down to a safe level. And the interim targets are levels that are not necessarily safe, but they're landmarks towards reduction of the of air pollution. So let's see. Here is another slide. Does anybody know Jeffrey Rose and these data? No. So here's, you've got to listen, because these data come from Kenya. And Jeffrey Rose made observations of the blood pressure in people living in rural Kenya and London workers. And the distribution in red over here was what he observed roughly in people in Kenya, blood pressure. It was blood pressure, actually, not risk. And then London looked like this. And his point in doing this was that when we want to protect public health, we want to move the distribution of risk from this higher number, which would be the blood pressure distribution in London, to the lower curve, which was at that time, his example was blood pressure in rural Kenya, males actually. And so in thinking about this, two things we want to do. So here's my idea about this, that you have a whale. Can you see the whale? Okay. And yet you're worried about moving this whole whale over, but you're also worried about the tail, because the people in the tail may have unacceptable risk. Okay, so they may be susceptible because they have underlying disease, or maybe those are the people who are living adjacent to the freeway, or an incinerator, or an industrial facility. So in our efforts to control disease, we're concerned about the whale and the whale's tail, where it is. In the United States, and I see an environmental justice t-shirt in the back, we're concerned about environmental justice, which is why are some people in the tail of this risk distribution, and how do we move it, and how do we make sure that we don't have people at an unacceptable risk. And they're very often there because of who they are and how society is structured. So have to think about this. So another important point is we take action when we think something causes something else. Okay, so PM 2.5, let's name some things it causes. Lynn, what are some bad things that PM 2.5 causes?
The risk of cardiovascular diseases.
Risk of cardiovascular, it causes it. Okay. Give the microphone to your colleague.
Respiratory ailments like asthma.
Causes asthma.
Mm-hmm.
Okay, what else? Go ahead. Things that PM 2.5 causes.
I'll deviate from health. Visibility.
Visibility. That's true. That's true. Here we'll ask HEI to figure in.
It exacerbates asthma.
It exacerbates asthma, you're sure? It causes exacerbation of asthma?
I would say.
Okay, all right.
Lung cancer.
Lung cancer. Okay, all right, enough of this. But the causal decision is a very important one. And again, you know, we spend a lot of time arguing about whether something causes something else. But if something causes something else, if PM 2.5 damages health, there's two things we want to know. Okay, and those are listed here. How much is the increase in risk? What is the relative risk? And the other thing we want to know in general is how much disease is caused by the agent. And that's what the global burden is about, how much disease is caused by the agent. But we really want to know two things. And the other is, what is the nature of the relationship between exposure and risk? Is it linear? Is it curve? What is the direction of the curve? Is there a threshold? So those are things we want to know about. And a lot of epidemiology, a lot of work supported by HEI is directed at the exposure-risk relationship. And some of it, of course, through the State of the Global Air, is directed at the burden of disease. So for policy purposes, the other question is, if some disease is caused by the agent, 10%, 20%, 30%, then we want to know, if you take action, how much you can reduce disease. And again, that's part of this burden estimation, saying, if we have this exposure causes that much disease, but if we could drop to interim target 1, then here's how much disease would be prevented, right? So those are theirs. And then there's just this interesting issue. This was mentioned yesterday. Causation in an individual. Who mentioned this yesterday? Somebody did. George did? Was it George? Yeah. And so this was a case in England where the court decided that a girl's death from asthma, respiratory illness, had been caused by the high pollution where she lived. So usually, and this is a problem, when you explain things to a policymaker, it may be very difficult. So I'm going to ask Kyros a question now. Kyros, there are 7 million people with deaths attributable to air pollution every year. How many of those people can you identify? How many of them do you know? Can you introduce me to the survivors of one?
Well, the answer is no, right? I mean, it's kind of a global statement in a way. So you're not pinpointing anyone, but out of the totality, this many people will die. So it's not individualized.
So you heard Kyros' answer. Is he right? So if I were a policymaker and I've been speaking to Kyros and said, you've got to do something about air pollution. Do I? Yes. And there's 7 million people a year dying prematurely. There's 5,000 of them right here in Nairobi. And he's told me this. And then I say, well, tell me about one. Introduce me to one. So part of the problem here is communication, because these are population level measures. Okay? And so it really is a bit challenging. So, but this case was a landmark case in the United Kingdom. Here is an Ethiopian colleague who is head of the World Health Organization, I think everybody knows. And Lynn, you were at the first WHO conference on air pollution, which is in November of 2019, if I remember right. And Dr. Tedros said that air pollution was the new tobacco. Okay, and there he is. So why would he say that? And he had that huge burden estimation. So part of the idea here is if you have a big number, that it should motivate action. Okay, and I think that was part of what he said. And so now he said this, the simple act of breathing is killing 7 million people a year. Okay, that's pretty dramatic. That's a powerful statement, 7 million people a year. And so how do we interpret that? How can this be going on? What does it mean that air pollution kills 7 million people a year? Does anybody want to take a crack at explaining that? It's a big number, we agree?
I'll give it a try. I think to quantify that number is like we are losing, every year we're losing Nairobi, like the size of Nairobi, because Nairobi has almost around 7 million people. So every year Nairobi is wiped out due to air pollution.
Okay, so that's a good analogy, and that would be a good way to explain the number. Agree, totally. And people have made comparisons like with tobacco, and I can't remember, it's like the number of deaths in the United States a year from tobacco is like 3 747 airplanes crashing every day or something. So to bring these numbers in the context is really good. But are those 7 million, wait a minute, one question. What's your chance of dying? Is it 100%? Well, look, come on, let's take the long term. What's the chance of dying? It's 100% for everybody. I guarantee you that in 100 years you're going to be dead. I'm sorry to give you the bad news. But true, right? True. So it's 100%. So what does it mean if it's killing 7 million people a year? Are these people who, if there were no air pollution, would live forever? Would they be immortal? No. Okay, so what's happening? They're dying earlier than they would have. Okay, so that's one important point about interpreting the numbers. So the 7 million people, if you remove air pollution, are not immortal. They're still going to die, but they're going to die somewhere later. Okay, so the simple act of breathing. So we can't stop breathing, correct? Or we die. So what is the comparison here? So we'll come back to this and what it means, because this gets at this idea of the counterfactual. So if you were Dr. Tedros and you had to explain this, we'll come back to this, because by the end of this workshop, everybody has to be able to speak for Dr. Tedros. Okay? So you have to be able to say what he meant. Okay, so there, we're coming back, I promise. Everybody's going to have to write down what he meant. All right, so the important first big idea that you have to remember is the counterfactual. Does that sound like a strange? Anybody heard of the counterfactual? Kiros has a few. So just think about what it says. It's counter to the facts. Okay, so the counterfactual is counter to the world as it is. Okay, so the counterfactual is something different, and that gets back to this 6.7 or 7 million. So look at this. This is the distribution of particulate matter exposure as estimated from models. So right here, and you can see here's China and India out here with the very high values. The higher income countries are over here. This is the annual average PM 2.5, and and you can see that there's a distribution. So that is where the 7 million deaths comes from. This is the real world exposure to PM 2.5. The counterfactual doesn't exist. Remember, it's counter to the facts. So in the counterfactual, there's no, in this example, there's no exposure above 2.4. Okay, so we've taken the real world and we've said, if we could change the world counter to the facts so that nobody experienced more than 2.4 micrograms per cubic meter annual average, here's what the distribution would look like. You can see we've gone from all these people exposed at high concentrations to now they're all down here. Okay? So that's the counterfactual for air pollution. And we'll come back. I'm going to give you a different example that's easier to think about. But this world doesn't exist, right? What's the annual average? Let's see, I know here it's 20 micrograms per cubic meter on the BAM of PM 2.5. Yeah, for Nairobi. So it's about 19, 20. And what we're saying is there's 19 or 20, but if the level was only 2 or 3 in Nairobi, in this counterfactual world, this is what we would have, and that's the burden. We would avoid by getting rid of all that exposure, getting rid of all this stuff, we would have that much less exposure, that much less premature death. Okay, so that's what you're calculating. So, counterfactual. Have to remember this. It actually underlies a lot of our thinking and data analysis, in fact, for those of you who are in epidemiology or biostatistics. So, we assume a world that doesn't exist, but theoretically could. So, generally, when we think about the counterfactual, we like to have some reason to think about a particular value. And sometimes this gets into argument. So the global burden of disease has estimates for obesity and inactivity. Okay, and what the counterfactual for obesity, I'm not sure, I think it's maybe no one has a BMI above 25. Well, that world would never exist. Okay, but that is the counterfactual, or we've all increased our activity to physical activity an hour a day. So counter to the facts, and I think it's a hard concept to explain. So let's pause for a moment and talk about counterfactual. So if Dr. Tedros says smoking causes 6.5 4 million deaths a year, cigarette smoking. What is the counterfactual? No smoking. Okay, so the counterfactual for that smoking is no smoking. Okay, and in theory, could the world have no smoking? Well, I was going to say yes, but you said, I mean, so you're being realistic and saying the tobacco industry is not going to go away. But we're trying. We're trying. So, okay, so there's reality. But in theory, there could be no smoking. I mean, the world once didn't have cigarettes, for sure. So that's out of the counterfactual. So a couple of other points. Attributable versus avoidable. So the 7 million deaths a year from air pollution that Dr. Tedros was talking about, that's attributable. Are they all avoidable? Can we magically tomorrow make the level of PM 2.5 in Nairobi 2.5? No, obviously not, right? So you can't do that. So then the question is, of that attributable burden, how much can we actually avoid through interventions? Okay, so there's an important distinction here. A little bit of history. Okay, this is the members of the Department of Epidemiology of Johns Hopkins in about 1935. That department, I was chair of that department for 14 years, and it was an important department. This person right here with a circle on him, Morton Levin, did one of the very first studies showing that smoking was strongly associated with lung cancer. But he also did something else. Yeah, and here's his paper, published in 1953. And he published this paper on the occurrence of lung cancer in man. And he proposed an important statistic that we still use called the attributable risk, okay, which is conceptually what underlies burden estimation. And if you looked up here, this is from the original paper, even back in 1950s, early 1950s in the United States, 70–80% of lung cancer was attributable to smoking. Okay, and it's even higher now. So here is the statistics. So we're now we're going to do a little bit of math. So the relative risk is the risk in those exposed, say smokers, to the risk in those not exposed, say never smokers. Okay, so that's the relative risk. And if it's 1, of course, there's no increase in risk. And if it's greater than 1, there's an increase. So for example, right now in the United States, the relative risk for developing lung cancer in smokers compared to never smokers is about 25. It's a huge, huge increase. It's probably less here. I'm sure that smoking causes lung cancer in Kenya and Ethiopia and Uganda and South Africa and Ghana and everywhere. But probably the risks are different because people in the US smoke pretty heavily and used to start very, very early. So the statistic that Levin proposed is called the population attributable risk. And it's very simple. It has the relative risk in it, -1, because that's the baseline risk, and the prevalence of what the exposure is. So conceptually, this is very, very simple. And you can see it goes from 0 to 1. Okay, so let's just say, for the sake of argument, everybody look at the statistics. P is the prevalence. RR is the relative risk, the risk in those exposed divided by the risk in those not exposed. We take away 1 because that's the baseline. So RR -1 is just the extra risk. Okay, so it's just the extra risk. And then we're going to multiply that by the prevalence of exposure, and the denominator is just that baseline risk plus the extra risk. So one more time, this is the extra risk in the population, RR -1, minus the baseline, times how many people are exposed, over 1, the baseline risk, plus the extra risk. So it's just the proportion of risk explained by the level of exposure and the relative risk. So if you think about what happens if the relative risk is 1, look at the formula. If the relative risk is 1, what is the value of the population attributable risk? This is easy math. 0. Right. It's 0. So it's RR is 1, RR minus 1 is 0, and it's 0 over 1, which is 0, right? Now let's just say, for the sake of argument, if the prevalence of exposure is 100 and the relative risk is very high, then this moves towards 100%. Okay? So it's very intuitive. If there's no exposure, there's no population attributable risk. If P goes up, then population attributable risk goes up. If RR goes up, population attributable risk goes up. And it makes very clear that in the comparison, in the counterfactual, we're thinking about changing the prevalence of exposure, basically. So we go back to that, and we've changed the prevalence of exposure, different concentrations. Yeah. The mathematical slide.
Yeah. Yeah, forgive my ignorance here as well. Yeah, so I'm just a little curious. It's mentioned there if the relative risk is it's 1,
right.
It indicates no increase in.
There's none of the risk is attributable. Exactly.
Okay.
Yeah.
Again, just for clarity, but I'm just curious. So does that mean, looking at the formula there, does that mean if, let's say, 50%, you know, if the numerator and numerator they're the same, so then you have 1. So does that mean if, say, Nairobi is 50 million people, sorry, not 50 million people, 3 million people are smoking, and 3 million people are not smoking? I don't know if that's supposed to be how it is.
So your prevalence is 0.5.
So,
exactly. So P is 0.5. And then if, let's say, the relative risk is 10, okay, so the top would be, P would be 0.5 times 9, which is 4.5, and it would be 4.5 over 1 plus 4.5. So it'd be 4.5 over 5.5, which is roughly 80%. Okay?
Okay, so
Yeah.
that's the most important, not necessarily the,
yeah.
okay.
So, yeah, so and actually we're going to do some calculations, but here is exactly what you're trying to talk about. So here are curves showing the population attributable risk for prevalence going up from 0 to 100, and the relative risk going from small to big. Okay? So you can see that, let's just, and this is where these relative risk numbers figure in. We're going to talk more about this. As the relative risk goes up, you can see the population attributable risk goes up. And you can see that as prevalence goes up, the lines go up. Okay, the population attributable risk goes up. So that's just that formula. That's just that formula. So here we're going to do some calculations. So I want each of you to try a calculation, or maybe you could do it by table. So maybe this table could do the first one and calculate the population attributable risk. And the next table can do the number 2, and the last table can do number 3. And way in the back, with Abra, you can do number 4 down here. Okay, and the table with Kiros, you can go back and do number 1. And the HEI table, you can do number 2. Okay, so we'll take it just a couple of minutes. So 1, 2, 3, 4, then back 1, 2. 1, 2, 3, 4, and back 1, 2. So do the calculation, do it yourselves, and then make sure you come up as a table with the right answer. No computers, Kiros. And you can't use Siri. No chat GPT. Are you calculating? You're not calculating. You have number 4 at the bottom.
The first one. Yeah. The young people are good with
Yeah.
maths, but
The bottom, 0.7. And
Okay, teach me. What do we put?
P is 0.5.
You're doing number 1.
Let's substitute the formula with
I actually haven't done the calculation.
The numbers, yeah.
the numbers.
Yeah, I'm just, you should come up with the same number around the table. We'll have a consensus number.
I think it's 20%.
How is this table doing? Good. Okay.
20%, which is equal to 0. Yes, the politician.
I want to understand the things because I don't. I don't want to explain.
0.2.
That is what we normally told.
You done? Did Uganda and Kenya get the same answer? Yes. You did? You're good. Good.
No, we are good. 20% or 0.2. I like these concepts of health. Your research is much easier than ours. Now, as we have to justify what is the...
Okay, is everybody ready for the answers? Okay. Table 1, what is your consensus answer?
One moment.
One moment.
Yeah, we need to, yes.
This is not a political thing.
No, now this is science.
This is
Today we are not in English, we're in science.
Okay, so the answer from table 1 for 0.5 and 1.5.
Just,
Are we ready?
percentage, yeah.
Percentage? Okay, table 1 is not ready.
Oh, it's ready.
It's what percent? 20%.
20%.
Okay, all right. That was very definitive. So let me ask this. Okay, all right. So table 1 is 20% important. Is 20% important?
Which depends on the disease, no?
Is it important? Would it get somebody? Would it get a politician's attention that 20% of the burden is due to something?
Relatively, it depends on the decision.
If it's death?
Yes.
Okay, all right. So let's go to table 2 in your calculation. Do we have a spokesperson here?
It's 0.905.
90.5%. Okay, fair enough. Okay, and is 90.5, does anybody know a disease where 90.5% of it's explainable by something? So that's lung cancer and smoking. That's lung cancer and smoking. So, think about that. So here we are, we tolerate 90% of lung cancer in most countries being from smoking. So that's a big policy message, right? Would be. Let's see, how are you guys doing? You're spokesperson.
0.047.
Say again?
0.047.
So it's about 5%. Yeah, about 5 5%, and that one's low because the prevalence is low, 0.1, and the risk is relatively small. So what would happen, here's another challenge for you. Go back to work, and now increase the prevalence to 0.9, and keep the relative risk of 1.5. And then we'll come back, I'll come back and ask you what you think. So this table is number 4.
That's 25.9%.
25.9, okay, and that's 0.7 and 1.5, so it's a relatively common exposure and sort of a moderate increase in risk. Okay, and how did this table do? And it's 20%, you agree? Okay, all right. And 90%. Okay, so we have that. So what you should get out of this is that something can be important. This table's recalculating at 0.9, and we'll see. Do you have your answer? 31%. So you went from 5% to 31%. So something could have a relatively small increase in risk, but cause a big burden of disease if it's a common exposure. And so we have examples of that. So, okay, so this is just some examples, and then you saw this. Let's see. Yeah, and you saw this figure already. Okay, so and again, we can make the slides available, I think, and then you can just take a look at this at your leisure. So the other point that you have to remember, and I think this is really in how you present these estimates to the public and to policymakers. So the difference between attributable and avoidable. Okay, so we can get smoking, the prevalence maybe down to 0. Maybe down to 0. That's where we want to go. And that's achievable because the world does not have to have cigarettes by any means. Okay, but if we're going to have motor vehicles and generate electricity, we are going to have particles. So we can't pretend that we're going to have the counterfactual down at 2.5 or 3. So if somebody came, if you go to the policymaker and you say, well, we can get rid of, 7 million premature deaths, but you really can't. Those are attributable, but they're not avoidable by any policy interventions we have right now. So, and we'll talk more about this, about how to use burden estimation to try and sort out what might be avoidable versus this attributable thing. So we're not going down to there. And you can think about, for example, the interim targets as places along the way here where you might want to get to. So there's our 5 micrograms per cubic meter, the WHO annual guideline, the new one, that is probably not achievable in very many places. Okay, probably not achievable. So the attributable burden, what we can get rid of, is never going to be what we promise if we say, well, we can avoid the 7 million. Maybe we can avoid 2 million. Maybe what we want to do is focus out here. Or in Nairobi, you want to focus on the most polluted areas and say, what can we do? Okay, so I think then maybe, I think, Cardi, I think I'll stop here and go to you. And then we'll come back. So.
Can I ask something? So, probably because people are familiar with controlled clinical trials, randomized controlled trials, wouldn't that be the right analogy to explain? Because you're talking about the population as free living society. Therefore, there is
very little. Oh, yeah, okay. Yeah, sorry. So I think in terms of understanding the concept of counterfactual, the attributable risk and so on and so forth, I think probably for people to understand it easily, to compare it with controlled trials where you actually are conducting an experiment and you can't control what people are exposed to, right? So you can actually have 0 exposure in a chamber or a small amount of exposure. So that could be the equivalent of your counterfactual. And the avoidable is if the experiment is now realistic. So is that the right analog? Maybe you're avoiding saying that, not confused, but.
I actually think it's maybe not the right, for this, I mean, I understand where you're going with this, around causal estimation, but no, I think the answer is not particularly. Before we go on, counterfactual. Again, let's say you are thinking about the burden of disease due to drug use, illicit drug use. Okay, in the United States, we have many, it's actually a very good example. In the United States, we have a terrible problem right now. We have about, you ready for the number? 50,000 deaths a year due to fentanyl overdose, the very powerful narcotic. Okay, so are those 50,000 deaths, and that's attributable. I mean, the death certificate says death due to fentanyl. Okay, so what would be the counterfactual world for thinking about the burden of death due to fentanyl? It's a little bit like Kyros' example, actually. The world would have no fentanyl, right? No illicit fentanyl. So that would be the counterfactual in that example. Do you have a problem of road accidents here? Yes. And do you have a problem of road accidents due to drinking too much alcohol and driving? Yeah, everybody does, right? So everybody. So what would the counterfactual be if you said we have in Kenya, I'll make up a number, 10,000 deaths a year due to drunken driving? So what is the counterfactual? No drunken driving. No drunken driving. Okay. So, and is no drunken driving achievable? Well, probably not. But that 10,000 deaths, you probably can avoid a lot of it through interventions. Okay. And so in the United States, and I suspect in Kenya or other countries, people have done interventions to reduce drunken driving. And that number of deaths has actually gone down. So I'm going to leave the counterfactual, but any other questions about the counterfactual or the concept of it? I mean, the name gives it away. It's counter to the facts. So it's comparing the world as it is to a world that doesn't exist. Okay? So for physical activity, the world as it exists is, you know, how much physical activity people are actually doing. And if I asked people to raise their hands and said, who's done some physical activity today? I'm not going to do it, don't worry. But some of you would raise your hands. And then if I said, who didn't do physical activity? A lot of you would raise your hands. So the counterfactual would be perhaps that everybody did physical activity, or the number who raised their hands went from 10% to 50%. Okay, so again, the world that doesn't exist. So I think Cardi's going to take over and give me a break. I guess your slides are here.
Okay, thank you. So, yes, I'm going to give an example of the South African situation because I was part of the burden of disease work that was done by the Burden of Disease Unit at the South African Medical Research Council. It was published last year, and this is a really large task. It involved numerous people, mostly researchers, people like statisticians, biostatisticians, epidemiologists, but also the climatologists and the meteorologists, because you've got to work with the pollution data and the meteorological data. So the ultimate goal, of course, we want to know from a research perspective, this is important for us, but we also want to try and inform our decision makers. So there was a meeting that was held about 2 weeks ago where I mentioned yesterday I'm on very good terms with our National Air Quality Officer. I spoke with her saying these 2 studies have been done, and I think it's really important that you have a good long session with the people who did this work so that you can understand what was done and how these findings may be useful for you going forward with your own work, whether it's the air quality management or the policy updating or regulations. So I'm going to start by, and it's so small, it's awful. Anyway, you can't possibly see that. Yeah, it's so tiny on the screen, and it's enormous on the slide. Anyway, the left-hand side table illustrates in 2012. So this is one of the first things that I want to mention, is that we've had so much pushback. Why is the data so old? So when this was published, it was 10 years later than when the data that we used, right? And why is that? Well, first of all, these are statistics from our Statistician General on the leading causes of death in South Africa. And those data are always about 5 years behind. A little bit like our cancer registry data. It takes time, and I'm sure it's similar in Kenya, to get those death certificates and organize all of that data. And then, of course, the work begins, and so, you can see, okay. The work begins, and that takes time. And John is going to go into the methods of it. I'm not going to talk about the methods now. I'm just going to give you the overview and the findings. But you can see that in South Africa, the leading cause of death in 2012 was HIV/AIDS, as expected. And then the statistic next to that is years of life lost. And I think that's intuitive, right? How many years? And it's by, there's so much going on the screen, I can't even see my slides. Let me just clear that. And what there? So the years of life lost is not just for the one individual. It's every year life lost for every individual who dies prematurely. And on the right-hand side, it's just a plot over time. So this is looking at all of the deaths from 1997 to 2012. I think it works out to about 8.5 million people who passed away during that period of time. And you can see this incredible trend with HIV/AIDS and tuberculosis, where there was a steady increase to the early 2000s and then a decline to 2012. And it's broken down by non-communicable disease, which is quite steady, but with a gradual increase compared to injuries and the non-communicable or infectious diseases at the bottom. So this is a very complicated slide, but it gives an overview of what is required when you're doing a burden of disease study. And I'm going to first show the ambient air pollution, and then I'm really going to focus more on the household, because I know we didn't talk about that enough in the last 2 days. So what happens here is we have to have population-weighted ambient air pollution concentrations. So in South Africa, we are fortunate to have some monitoring data, but it wasn't necessarily enough to be able to cover the whole country, right? And that would be the same for Kenya. You don't have a wide enough network. So we used a chemistry model and simulated the missing places using the ground base stations. And all of this was transformed into a big grid of PM2.5 and ozone. Those are the two pollutants that we focused on. And it has to be weighted by the population, so that, it's not to say it's not as important if there's only, 10 people living in a town versus 100 million people or 10 million people living in a city or whatever. But we have to take that into consideration when we're doing the calculations. And then the next step was working towards the relative risk, which John has already mentioned. We happen to use integrated exposure response curves, which John is going to speak to. And the outcomes of interest were lower respiratory infections, trachea, bronchi, and lung cancers, diabetes, ischemic heart disease, stroke, and COPD. And then that was for PM2.5, and for ozone we used COPD. And then we get to the attributable burden of disease, which we've just heard about. And this we broke down into both deaths, years of life lost, which we've spoken of, years of life lived with a disability. I think that's also pretty intuitive. And then DALYs, which are disability adjusted life years. And so this might be a term that we're not all familiar with, and John may be explaining it, but I thought I could. Should I just give okay. So a disability-adjusted life year is a measure of the overall disease burden expressed as the number of years lost due to ill health, disability, or early death. So how's the easiest way to translate that? You want to say something, John? Yeah.
So think about a disease that lasts a while, COPD, chronic obstructive pulmonary disease, the disease that smokers get that disables them. So somebody might get COPD, be diagnosed, let's say at age 60, and at age 70, they die. And they would have lived, if they not had COPD, let's say till 80. So they lost 10 years of life, gone, that's the early death, and they lived 10 years of life with COPD. And while they were living with COPD, they got short of breath, and they couldn't go shopping, and then it got worse, and when they put their clothes on, they got short of breath, and they had disability. So they have 10 years of early life plus 10 years of disability, and what the global burden does is it assigns weights depending on the disease to that 10 years. So the disability-adjusted life years would be the 10 plus 10 times, I'll make it up, 0.6. So there'd be 16 years of 16 DALYs, disability-adjusted life years, 10 years of bad living plus 10 years of early that could have been lived. And so what the IHME, the Global Burden of Disease, does, it has disability weights for all these different diseases based on survey data and other things. It's a gigantic amount of data.
Thanks, John. So then if we have a look at what the data tell us for the population-weighted annual mean concentrations, and this is for PM2.5, the plot on the left-hand side, and then the mean of the 6-month period with the highest mean 8-hour daily maximum ozone concentrations. And this is ambient ozone concentrations. And the scale here, so everything was done at the level of district municipality, because that's the lowest level at which we could get the death data. So the districts in South Africa with the highest PM2.5 is the city of Johannesburg, includes the city of Johannesburg and the city of Tshwane or Pretoria, where I live. You can see right in the middle of the country, in the sort of northern parts. And then the ozone levels, interestingly, ozone is very much more affected by regional processes in Southern Africa, and you can see the high concentrations of ozone in the eastern parts of South Africa, which is the KwaZulu-Natal or the city of Durban. Then if we look at the age standardized death and then disability adjusted life years, and these are rates per 100,000, and we're looking at this for the distribution between males, females, and all persons together, and the change in time. So from the first time that this burden of disease work was done in the year 2000, and then in 2012, and a midpoint, just 6 years, basically, 12 and a half, between the two, just to get a sense of what was it like halfway through. And we can see that there is very little variation in these death rates and age-standardized DALY rates for both PM2.5 and ozone. There's very little variation between the male and the females, and even in the absolute numbers. Maybe actually, I'm not even going to hazard a guess at anything, but we can see that they're round about, if we look for all persons for 2012, it was 51. That's the age-standardized death rates per 100,000 people in 2012, which is actually quite high. It's a little bit higher than the 49. Well, not really. So these are the results that come out of conducting this type of analysis. So this figure then, and again, I apologize that it's so small, it's enormous on my computer, This is the deaths that are attributable to PM2.5 by disease condition, and we're looking at a pie chart for 2012, 2000 and 2012 on your right-hand side. And it's also got the total number of deaths for each of these. So you can see, first of all, that the DALYs are a lot more, and that's what John just explained. So that's taking into consideration both the time that someone lives with a disease as well as the time that they lost life. And it's broken down by the disease of interests, and you can see, and it was the very first disease raised earlier of what PM2.5 is known to cause is cardiovascular disease. A third of these deaths related to air pollution exposure, ambient air pollution exposure, were cardiovascular diseases. And you can then look at the similar for ozone. So if I focus then on the key findings from the ambient air pollution, at a very high level, we were able to say that approximately 70% of the total South African population, which is around 60 million people, lived in areas exposed to PM2.5 concentration above our current national ambient air quality standard of 20 micrograms per cubic meter. That is unbelievable. Our standard is 4 times higher than the WHO guideline of 5. Around 51 million people, which is around 97%, were exposed to harmful concentrations of PM2.5 above 10 micrograms. I mean, this is an enormous problem. It's obvious that it's an enormous problem. And then for ozone, it was about 49 million South Africans, or 94%, were exposed above the 61 parts per billion South African 8-hour standard during the 6-month high ozone season. So those are very powerful statements, but of course someone's going to know, well, what am I going to do with them? And I'm going to get to that in a minute, but I'll quickly turn to HAP. Is that okay? So household air pollution in South Africa might have a slightly different story to the situation in Kenya. So post-apartheid, our government adopted policies to try and address the inequities and inequalities by improving basic services, including electrification. And many of these were successful, but as was discussed yesterday, there's this competing challenge of actually paying for the electricity, plus the services, things like are broken, for example, with cable theft. And in rural areas and large informal areas adjacent to our cities, these services lag. So electricity does not necessarily translate into electricity use, and we know that. There's the affordability issue, and then we also heard about stacking yesterday, stacking and switching between energy sources, depending on the time of the month, affordability, cultural taste preference, and so on. And then we are facing an enormous challenge at the moment. We have what is called load shedding, which is rolling blackouts. We haven't had a day without rolling blackouts since September last year, and it's projected that we will have rolling blackouts at a stage, the highest stage is stage 8, at stage 6 every single day this year. It's the most radical we've ever had. It's crippling our economy. So what did the household study do? The study aimed to estimate the disease burden attributable to household air pollution in South Africa, again for the same 3 time points, 2000, 2006, 2012. And the burden of disease is all those things that we just mentioned, deaths, years of life lost, years lived with disability, and the DALYs. And then on the right-hand side, it's just a snippet of how it was estimated, or how the people who crunched the numbers brought the data together. So we focused on populations cooking with clean fuels. So those were considered our unexposed group. And then the population cooking with solid fuels. And we had to get that information from our census. And you can see there's a problem already, because the census was conducted in 2001. Then we had a community survey, which doesn't cover the whole country, in 2007. Fortunately, we had another census in 2011. That's why we used the 2012 data, the death data, because we could use the 2011 census data. We only had another census post-COVID. Then we had to use global models of HAP PM2.5 exposure to assign our PM2.5 exposures based on age and gender. And then we used the integrated exposure response curves to get our relative risks. And we also did, used some systematic reviews. And essentially, we then get to this attributable burden of disease, which John has been talking about. I'm not going to go through that because you've already talked about it, and it's complicated, but it's the same as what I've just shown. So what did we find? So first of all, in 2012, approximately 9 million people, so almost 1/5 or 1 in 5 South Africans were exposed to household air pollution as a result of cooking with solid fuels. Between 2000 and 2006, the proportion of people exposed cooking with solid fuels decreased. So that's a really good thing. It means that there was some real progress made in getting the breathing zone where people live and play in their homes improved. And then there was a modest decrease, so it's less, it's only about 18% between 2006 and 2012. And there's a number of reasons for this. It could be to do with the economy, affordability. It was a time where we were not really seeing very many increases in salaries and so on, so people couldn't really turn to more, electricity is not always affordable. This table breaks down the deaths and the DALYs by these years by the outcomes, the health outcomes of interest, so in relation to household air pollution exposure and specifically PM2.5. But the most important thing here really is to look at those total numbers, so the total attributable burdens. So the deaths it looks like there's a steady decline over time, right? And there is. It's not an enormous number. It's about 4,000 difference or just less. But still, these numbers are large. And when we think about how they could actually be preventable, it's alarming. What's especially alarming are the DALYs. So, of course, loss of life is really important. But at the same time, all countries want economically productive human beings. And if we look at those DALYs, it's 208,000 people, not people, lives and years and disability and all of that mixed in, which means we're not having that productivity, we're losing that. And that's not good, especially in Africa where we're on a development trajectory. Again, this is similar to the air pollution, ambient air pollution. It's just the deaths by disease condition. It's very similar to before, except there's a big change. Lower respiratory tract infections shifts into the top position over cardiovascular disease. So we know this. In South Africa, we have a terrible problem with respiratory tract infection being the 3rd leading cause of death in children under 5. And so we can see here that speaks intuitively to this problem that we see. It's more than a 1/3 in males and females. So what are the key findings? And I'm almost done. So I've already mentioned the proportion of people exposed to household air pollution, and around 9,000 people who die every year, around 9,000. The number of people using solid fuels has decreased. This may be due to electrification, but it could also be because we are starting to see more people getting creative with renewable energy. Even though it is extremely expensive, I can't afford it. But some people are getting creative with things like cooking, for example. There's things called wonder bags and solar cookers, and so people are getting creative. I haven't gone into the provincial analysis, but there was a provincial analysis done, and that was actually more important for our decision makers because they want to know district and province level for this kind of thing, because people want to know, what can I do at my level of jurisdiction? What's going on in my world? And then while electricity may have increased, the affordability, reliability will restrict its use, and this clean transition is really super important. So burden of disease and comparative risk assessment studies can be very useful to help policymakers decide what to do. And we have to use these to make recommendations. So the last slide that I'll put up are some of the recommendations that were put forward by the researchers to the policymakers. And this is my last slide, except for one which is a quote. And I'm only going to mention two things. The one is that it's saying that we need monitoring stations, comprehensive monitoring stations. So that is a call or a plea to our governments to please improve the ones that we've got, as well as add additional ones, because it does help fill the gaps, even though we can get data from elsewhere. And then the second critical one was the need for strengthening and enforcement of our air quality legislation. So what did our National Air Quality Officer say at that meeting 2 weeks ago? So she said that this work is very important. It shows how critical the work of air quality managers is, and that they need to up the quality of their reporting and monitoring sites. She said there's a lot of work to still do, but she agreed with the recommendations and that she'd be taking them up to the next level.
Thank you, Cardi. It's great. And maybe the household air pollution is actually a good example, because we saw the prevalence of what people were using solid fuels, and it was about 20% or so. So that was P, right? And then the other piece of this is the RR. Okay, and remember, P times RR minus 1 over 1 plus P times RR minus 1, right? So what are the two, well, before we go to coffee, I've never seen so many jet-lagged people who live right here. I don't know. So if you want to reduce the burden of disease, in that very simple formula, what do you do? So what are the two ways to reduce the burden of disease in the formula? The prevalence. Reduce the prevalence. And what is the other thing you can do? Reduce RR, right? So it's very simple. You can reduce the prevalence, or you can reduce RR. So electrification would be reducing the prevalence, right? What about changing the fuel mix to fuels, cleaner fuels or cleaner cook stoves, which a lot of work has been done on? And that would probably be trying to reduce the RR. Okay, so that formula really can tell you a lot about thinking about prevention and dealing with the disease burden. Yes? Well, it could. It depends on how it affects the fuel mix. So the question was, would providing electricity reduce the RR? You could think about that as changing the fuel mix, again, depending on what people, how they're responding to this. But I think that very simple formula, you have to remember it. And what's the other important thing you're remembering from today so far? Well, now I've got another thing. Attributable and avoidable. And what's the other big concept that you're going to remember? The counterfactual. Okay, so you can't forget the counterfactual. Okay, so I think with that, we've all earned coffee, a coffee break. Yes, Alex.
Thank you. So I need clarification from Karad about the 70%. You mentioned that 70% of the population is exposed to higher, air pollution. Yes. So I suspect this is the total population of South Africa. So how did you go about this? Do you have monitoring sites all over? Did you extrapolate?
Yeah, we'll come back to this. We'll come back to this. So the question really is, the prevalence is very high, and how did they get that calculated, right now, Alex, roughly? So we'll take a break till quarter after 11, and we'll come back refreshed and do some more of this. Okay, so we'll take a break till quarter after. And so hopefully now everybody remembers the formula for population attributable risk, P times RR minus 1 over 1 plus P times RR minus 1. You remember attributable versus avoidable. And what's the third thing you have to remember? The counterfactual. Do not forget the counterfactual. It's never going to leave your minds again. Never. Okay. All right. That's good. So I'm just going to make a comment, and I'm not going to spend much time on this. So we've been using the term health impact assessment and talking about burden of disease. And I'm just going to say that health impact assessment involves more. And I'm going to leave it at that, and we'll send you these slides. So if you think about health impact assessment, if you begin to change, let's say, the fuel mix to reduce disease burden, then you have climate consequences, for example. You may have consequences for workplaces and other things. And here is a slide that talks about the fact that health impact assessment involves looking at everything. Okay, and for burden estimation, we're just looking at the amount of disease attributable to something. Okay, so I think in the interest of time, we'll skip this, and here's the point about this, that burden estimation is part of the health impact assessment. And we talked about attributable and avoidable, and Cardi gave us the introduction to DALYs and so on. So we've got all that. Now, we're going to go on to how are these calculations actually done. And are you ready? Look at that. Okay, so this comes from the Global Burden of Disease. You know, the folks in Seattle, IHME, the Institute for Health Metrics and Evaluation that Chris Murray chairs, that puts out the Global Burden of Disease estimates. And so far they're delayed. The last estimates were for 2019. And COVID has delayed them because it's changed mortality statistics so sharply in some places that they're trying to sort out the actual numbers of deaths. Now, I show you this complex diagram because it's based on that same formula that I showed you, but there's a lot of things in here that are done and different steps. And so what you want to appreciate, here is the output of this whole machinery, is years of life lived with disability and years of life lost. And you add that up and you get DALYs. Okay, so the output is what Cardi talked about in terms of burden estimation, and it takes a lot to get there. Okay, the way they do it. Now they have, Cardi, when you did your work in South Africa, how big was the team? You mentioned a whole lot of people. Were there 20 people? More than 20 people. Okay, so it's a big exercise. And if you were to go to Seattle, to the offices where they do these calculations, there's probably 100 people, at least. It's a big enterprise paid for by the Gates Foundation. And it was, Bill Gates was basically said, if we're going to pay money to prevent disease, we need some metrics of how much disease we're preventing. What is the target and what progress have we made? So here's the diagram about what happens. This is the general diagram. And here's the diagram for air pollution. Okay, and don't worry about the details here. And we heard from Cardi, what do we need to estimate the burden from air pollution? Well, we need to know what people are exposed to, right? What is the level of exposure? We need to know what is the risk at different levels of exposure. Okay, and then we need our counterfactual scenario. So the way the Global Burden of Disease does this is they use big air pollution models that use monitoring data, satellite data, other data to say, here's what the levels are for different grids in Nairobi, in New York City, in Kampala. Then they use epidemiological studies, and again, a fairly complicated analysis to say, here's the risk of dying, the risk of COPD at different levels of air pollution. So they have a dose response function. The more the exposure, the higher the risk. And so the comparison is, if I'm here and I go down here on the curve, what is the change in risk? And that gets translated then into the deaths and the DALYs. So the other question you might ask is, what is the counterfactual for air pollution used by the Global Burden of Disease? It's not easy to find. Okay, so what is the counterfactual not? It's not 0 micrograms per cubic meter of PM 2.5. Can we get to, we said we can get to 0 smoking, right? We agree? But we can't get to 0 micrograms. Nature makes particles, right? So we're going to have some background. And then assuming we want electricity and cars and trucks and other things, we're going to have some PM. So here is the counterfactual for air pollution, which they call the theoretical minimum risk exposure level. And they have theoretical minimum exposure levels, risk exposure levels, for all the different diseases for which they do these estimates. So read that and see if it makes any sense to you. So here, I'll read it aloud. It'd be like a bedtime story. Stay awake. The TMREL was assigned a uniform distribution with lower upper bounds given by the average of the minimum and fifth percentiles of outdoor air pollution cohort studies exposure distributions conducted in North America, with the assumption that current evidence was insufficient to precisely characterize the shape of the concentration response function below the fifth percentile of the exposure distributions. You bored yet? Yeah. So the TMREL was defined as a uniform distribution rather than blah, 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 okay? So now we're sitting and trying to explain the burden estimates to somebody. And we just said, Dr. Tedros, 7 million. And then some wise reporter says, well, Dr. Tedros, what was the counterfactual? That's it. So can you imagine explaining that to somebody? How about a reporter? Yeah, so you just can't do it. So, and the point I would actually make is that what they've done is they've taken the epidemiological studies, they've looked at what people were exposed to in those studies, they've taken the lower end of those exposures and picked 2 points on that to have some uncertainty. So this has nothing to do with avoidable. It has absolutely zero to do with avoidable. So remember that. So this is, if anybody says, if you're explaining this to somebody, just say it's complicated, okay? And that's all you need to do, because the rest of this is, you know, it's just very hard to explain. So, yeah. Yeah. Oh, hey.
The last statement there, or the last sentence, so the bounds they've picked is 2.4 and 5.9.
Yep.
But they seem reasonable. And then also maybe, because I think you're teaching us how to simplify things, even though it's kind of complicated, but they picked like a lower and upper bound, which is about, at least we know the value, 2.4 to about 5.9.
Yeah, so a couple things. So the question is the principle for reaching these the right one? And the idea here is very similar to the WHO guidelines, which are based on a very similar approach to get to that 5, where basically it followed this, taking the epidemiological studies and saying, where don't we see a risk? And that's sort of what they're doing here. So that's okay, but it's not what is avoidable, right? I mean, so this is for attribution, but not what is avoidable. So is this a reasonable approach? Sure. One point I'll make is that they're developing these TMRELs for every exposure in the GBD. And so if they do this for obesity, if they do this for whatever, they're not comparable. So one thing you shouldn't do is say, gosh, obesity causes as many deaths as smoking. We ought to forget about smoking and put all our money into prevention of overweight and obesity. So the counterfactuals are very different. And what you're seeing here in all this jargon is what is the principle by which they got there, which is take the epidemiological studies, go to the lower end, and take 2 points on the distribution, essentially, after defining this as a particular kind of distribution. So the principle's okay. Is this easy to explain? No. Okay. And in fact, Cardi and I were looking yesterday for counterfactuals, and there's a 300-page appendix to their paper in Lancet where you have to go through all this to find the counterfactuals. So it's not easy. So, yeah, any other questions about this? I mean, again, this is just the inside of the machine that makes these numbers and how it works. Other questions? Okay. All right, so you've seen, you know this stuff. And I'll just, I think what we're going to do now is go to how do we get these numbers? And I think we're going to go through the AirQ Plus and principles. But what do you need? I think you know this now. So you need an estimate of exposure, or what the exposure distribution is. And that comes from monitoring and models for air pollution, which is we just heard for South Africa. You need an exposure-response relationship. And what South Africa did and what people did is they used this so-called integrated exposure response, IER. What this is putting the epidemiological studies together on air pollution, pooling the data, and modeling it. Okay? And there are people who spend an awful lot of time doing that and arguing about what is the right way to do it. Okay? And then you need what the population demographics are, the South Africa census of 2011. And then you need the population mortality or morbidity statistics, which hopefully you can get somewhere. Some data, you know, for those of you working with the GeoHealth Hub, it's very hard to get hold of hospitalization data. It's not some central office you walk into and say, here's my flash drive, give me all the hospital data for Kampala. Okay, much harder. So that's what you need. And this is where this stuff comes from. So I think just one other last point, then I'm going to go turn to Kiros and Abra and others to talk about these calculations. What are a useful set of counterfactuals around avoidable? Avoidable. So we said the attributable was this stuff, okay, which is very hard to explain. But if you want to do avoidable, wouldn't useful counterfactuals be the WHO interim targets? Okay, so if you were going to do some analysis then, you could say, look, we're right now at tier whatever, and we want to go down to, you know, tier 2 from tier 3, whatever it is. So they would represent useful targets. So I think with that, we'll come back to this. Should we go to Ethiopia, Kiros? What would you like to do?
So we have the other file, right? The one I sent you. So I'm just going to get started, and then I'll turn it on to over to Abara, because this is kind of the framework that's going to be similar for Kenya and for Lynn as well. So maybe after Abara, I think both Lynn and Otieno could give some context as well. So John has mentioned the AirQ Plus, software. Just historically, this was actually done for Europe in the WHO office in Bonn, I guess. And the first version was like written for 2005, and the relative risk estimate that they actually use, even in these calculations that we're going to show you, are based on data from Europe, but the evidence is actually kind of comparable. I think the first one was in 2005, and then they updated it a little, and people started using it, so they have actually even added other languages and things like that, so it has become a global tool for making calculations. So the software itself is written in Java, so you don't even need to install it in your own machine. You can actually just download it, and by double-clicking, you can start using it. So it's a very, very user-friendly platform. So the link is over there. I think if those of you who have used it, Obviously, you will find it very easy, but anyone could actually try to play with that. So Abera has put together a set of slides which are really nicely laid out. So you click on that link from the website. If you Google AirQ Plus, on the internet, you'll get to this. I think now we are in version 2.2 point something. So once you click, then you will get to that kind of platform, and then you go down to AirQ Plus and you install it into basically you start double clicking and start using it in a way. Yeah, I mean you can download it to your machine, but I think you really starting using it without having all the files, all the back ends into your computer. And then once you have downloaded and unzipped it, then you will have that window AirQ Plus, and by double clicking it, you can actually go to basically next steps. We might come back to some details, but for now, I think that's probably kind of all you have to do to start using it. And John has already mentioned, in terms of the input data that are needed, and we'll come back to it as well. So this has been done for Kampala, it has been done for Nairobi, and the example that we have here is essentially for Addis Ababa. So I'll just, use this slide to point out what the, ingredients are, and then I'll turn it over to Abera to talk about specifically what was done for Addis. So you need data, and it has to be for a specific year, so that your conclusions are going to be time specific. You need some sense of the total population of your area for which you're calculating health impacts assessment. In this case, it's the city of Addis Ababa, and it was 4.8 million, estimate for that year. And then you need to have what portion of the population at risk is, in this case, a population which is more than 30 years old, which, and then 34% of the adult population greater than 30 years, older than 30 years old was essentially 1.6 million. Then you need to have the number of adult deaths, but excluding accidents, right? Because you cannot expect people, to die from accidents and then attribute them to air pollution. So you're kind of, honing down to what you really care about. And then incidence of adult deaths per 100,000. And then, of course, with these ingredients, then you can go to the tools and try to, to do the analysis. So I think probably I should turn it over to Abera at this point, because he can tell us exactly what was done as was published in the paper. Yeah, maybe a question first, yeah.
Thank you. I'm so sorry I have questions, but it's very interesting.
Absolutely,
I'm
yeah.
finding
That's why we're here.
Yeah, and I see, again, it's just going back to everything's as good as your assumptions. So I see the data is the population at risk are people above 30 years. Why doesn't it include children? I'm just curious. And then I'm a pediatrician and a pulmonologist, so maybe that's my bias. And then please go back to that slide. Sorry, no, the one that has that.
Okay.
Yeah, so I just noticed, yeah, despite you have your total population, but it's really adult data. Maybe that's my comment here. Thank you.
Yeah. Well, actually, I was thinking about that. I'm not sure whether there was some calculation on the relative risk that was specific to that age. Conceptually, I don't see a reason for why you wouldn't include children, actually. I don't know, do you know, John or Karadi? Yeah, or Pallavi?
I will. Oops. I'm going to guess, and I'll have to take a look at the documentation, that, in fact, the European studies that were available from which they calculated the exposure response were all adult cohorts, and the and the burden for children, I mean, is going to be largely driven in this part of the world by household air pollution, and of course, ARI and mortality from ARI. So I think, and that's not an issue in Europe particularly. I mean, there's some deaths, of course, but it's not linked. Yeah.
So I think conceptually the tool should be usable for any age, but I think the contextualized data from which they are, extracting the burden estimate, I mean the risk estimate are based on that population. So you're basically being specific, but the tool itself actually could be used because you have the ability to play around with the relative risk, right? So again, going back to the either counterfactual world in a way, or even getting some data as they develop, yeah. So, but that's a very good question. Yeah.
Sorry, thank you. So in the operational manual for the AirQ Plus tool, they refer to the exposure period as 1 year and above, the long-term exposure period. Like for instance, if, let me say Ethiopia had an average PM 2.5 or maybe 50 for 2020, so, and then they calculate and get the attributable death. So they say for 2020, maybe 50,000 deaths would have been attributed to the PM 2.5 at this average. But the exposure period, how long have these people been exposed to? They say 1 year and above. So the confusion is with the 1 year and above. If someone has been exposed, maybe they've stayed in this town for 5 years. Another one has stayed in the same city for 10 years. Another one has stayed in the same city for 20 years. Are they at the same risk? My issue is always with the exposure time period. I don't know.
I think this is the acute versus chronic.
So, so I mean, this goes back to assumptions.
Yeah, right.
And there's an implicit assumption that the modeled estimate at that particular point in time reflects lifetime exposure or some biologically relevant exposure. Yeah. And I think your question gets at the fact that that may not be the case. Maybe the exposure 20 years ago was more important than the exposure yesterday or last year. Right. So this really comes from, these risk estimates are based on epidemiological studies that have exposure estimates in the studies for some window of time. It's sort of an arbitrary window because it depends on when the studies started, when they began to make measurements. And so your point is a good one, and this just gets at one of the assumptions. So if we make an estimate today, let's say, for the annual average exposure at this hotel, and then you say, well, we've all been exposed to that all our lives, it's not the case, right? There's exposure misclassification. Or we estimate for Otieno's house, and how long have you lived in your current house? 40 years. Well, you're an exception, 40 years. So maybe his estimate is pretty good, right? For his current thing. I've lived in my current house 6 years. So the exposure level at my house now would not represent what I've been exposed to all my life. So there's a lot of assumptions. And these are some of the weaknesses, the epidemiological data that we use for this.
Yeah, and if you think of all the daily time series analysis, right? So everyone has been exposed to so many things, over their life, but you're really trying to associate daily fluctuations in air pollution with daily mortality in an aggregate level, right? So you're making very, very strong assumptions that, you're focusing on the, the fluctuations affecting, or at least leading to premature death or morbidity, right? But it doesn't mean that everyone that comes to that hospital or leaving the city has the same experience growing up or living their lives, right? So I think, that acute short-term, kind of effect level is also kind of clouding this. So again, the estimates are as good as the assumptions. Yeah. So Abra, maybe you can take over from here and talk about Ethiopia, and then we can fill in gaps, and I don't know, Lynn or Otieno would also fill in. Yeah.
Thank you, Klaus. When we had 3 years data, the story behind is we made very nice manuscript with descriptive analysis, trend analysis, and pattern analysis as well. And we submitted to the Journal of Environmental Epidemiology, very strong journal. And then they said the paper is fine, but where is the health component? And because with this trend, we have done hospital-based data, but that's not yet matured. We require, multiple years. And therefore, that journal indicated us, you see, there is a WHO AirQ, and then you can use it. And therefore, with this AirQ module, what they want to see is what if, for example, in our 3 years analysis, the concentration microgram per cubic meter is about 42. Okay, what will happen to the risk of dying if the exposure of 42 is reduced, say, to the first level of interim concentration, which is 35? What then to 25? What then to 15? And then what then to the annual 2005 mean, which was at that time 10 micrograms per cubic meter? And therefore, that kind of really calculation will show the risk of dying because of reducing from that level to that level. And for policy making, this is really essentially very important. They can show, they can see it visibly. And therefore, once really you are able to download, it's straightforward. What's difficult is to generate data, this data, which requires, the model requires, the model for calculating is having an embedded relative risk model. So it requires all causes of mortality, all age group, all causes of mortality greater than 30 years, all mortality except accident and injury. We shouldn't really include injuries and accident, that air-related mortality. Mortality due to accident, then that's for calculation. We had 7% actually. And so on. There are some data very essential. So then the other question in terms of getting the data is the challenges of uncertainties, like the population data in Addis. Sometimes we get, the government source will give you 3.8 million. Others will say 5 million. The mayor will say, so which one is really valid? Very difficult. But because we know how much it might be according to our speculation, then we felt very comfortable to take the population size of Addis Ababa from the United Nations population, records, which was 4.8 million. Then another question is then, these death rates and incidence rates, where should we get it? It was really very difficult, but fortunately, we had a burial, autopsy. Like in Addis, we have got about 90 burial sites when people are, dying, then they are entertained then. And therefore, there is an autopsy that will inquire the cause of death. So they had those data for a number of years, over 15 years. And that was really very excellent, to have very valid data. So once you have got this, you just simply go to the procedure. It's not very challenging, I make sure. So we'll share these slides to you, and there are examples which we did it purposely so that we learn from that. So this is a population. The assumption, 34% of the 2020 burial mortality minus 7%. So that kind of assumptions should be then. Otherwise, the first really thing is from 42 to 35. This is the model actually. And we have to insert what the model is saying, say in terms of incidence and other stuffs. So you just simply plug, and plug, and then finally, you do for all calculations. So we had 3 BAM sites, 3 BAM concentrations. One is our Johels, and 2 from embassy, US embassy. So we have to calculate respectively. This is straightforward, but the trick is here. You see, like Tash means our site. The concentration is 42.4, and the risk of dying from that concentration, if we just reduce the concentration to 35, which is very small reduction, then the risk of dying is about 502 people. So, and it goes on from 42 to 25, it is 1,147. It has 95 confidence interval, the upper and the lower as well. And it goes on, but if you just see the last one with 10 micrograms per cubic meter, the risk of reducing the disease by 2,043 people. So the question is, I mean, this is a scientific theoretical work, but the question is, would these really results would be palatable by a policymaker where diseases are very much rampant, for example, in Ethiopia because of disease, because of malaria? Does that make any sense? I don't know, but Samit will explain it. But very important is, because there is spatial variability, 42, one BAM, 34, another BAM, and 24, another BAM. So the risk of dying from the lower concentration is very, very low. That's a good message. But otherwise, let me just give you uncertainties. Now, models are based on assumptions, but inherent, with inherent uncertainties. One is the population number. Local government reports they are hiding numbers. They don't want to show us. That's really very difficult, but we have to acknowledge we have taken this population data from this source. That's most important. A small number of days calculated at who cutoff compared to no existing days or war or days because of what I just mentioned, which is a priority one, air pollution or perhaps days because of starvation or because of some disease. Otherwise, if we are to calculate the risk of dying by 2021, then it will have different stories. That's very stringent, very stringent. And mortality data certainty is also very useful, I just said. But otherwise, very important really uncertainty is we are having three PM measuring monitors in Addis. Not really representative for the entire space that Addis is located. So would that be meaningful? Then that's also a question. But otherwise, as we have discussed, it's always very smart to be satellite-based data as integrated with ground level data. So the slides Victor will share for you, but if you will have any questions, then you can email and we can assist you. But otherwise in Kenya, Otieno has done it, and also Lynn in Uganda has done it. It's not very, very difficult. Thank you.
Thanks, Abera. So I think, yeah. Okay. So just before we go on to, Otieno, who is ready, so just to go back a little bit into the tool, let me see. Yeah, so here actually we didn't go a lot into the live demonstration of the AirQ Plus tool. Let me see. Yeah, so in this case, if you look at the top, it says impact assessment, long-term effect, ambient, right? So if you drop down, there are actually many options that you can do. It's not only this. So I think the tool has more, more things, to offer. And then, in terms of the pollution concentration, you have two possibilities. You can input the mean value, which is what Abera did, or input air quality data, in a different setting. So in this case, 42.4 was actually the mean value. And then just for your own documentation, the location and things like that are actually context specific. And then, you can have comments, this is more about the documentation in terms of location and things like that. So one thing to say is, there were three mean values that Abera used. The one for the TASH, which is the site for the GeoHealth Hub. It was actually cited after following a very well laid out SOP, standard operation procedure, because we wanted it to be representative of what the city is experiencing. As opposed to the embassy, sites, one of them was right at the site of the embassy, and it's known to be more or less kind of closer to the background level, which is not going to be representative of what the city population is, experiencing. And then the second embassy site was at the school where most of the embassy parents' children were actually going to school. So their purpose was to monitor their own staff and their families' exposure, which doesn't align with what the city itself is experiencing. So there is potential misclassification, right? Because you're relying on one monitor, but you have 4.8 million people living around the city. So how do you characterize what the mean value should be? You know, that's another issue. But most daily time series studies actually are basically based on one central site monitor. But the citing of that is actually very important. So the health impact also is kind of, you know, similar. When you look at the embassy data, you basically have no attributable deaths until you go way down, right? That's not going to be realistic, right? So I think the numbers mean something as long as the exposure values and the input values are actually meaningful or appropriate. So just to point that out. Other than that, I think if you start playing with the tool, there is actually a documentation, a PDF file that gives you know, the details about the history and you know, what each of the tools actually give you as an output. Then it's actually very easy to follow. It's a remarkably strong tool for what it does. Alabi, you will have word of wisdom.
No, I actually just wanted to add that there is a report that the WHO produced for the city of Accra in Ghana, where they did the exactly same analysis, and because it was done with the city, they have included a lot of data on, you know, how did we decide what the population is, how did we decide the incidence rate, etc. So if you want to start playing with this, you have Abera's paper here and all these slides and also that report. So we will include all of those materials with the workshop content. So you have a few different examples to look at and decide how you can work with it in your city.
So the key messages are understanding what the tool can or cannot do. So you don't want to overemphasize in terms of what it offers, and then understanding what the steps to take are. And then, you know, if any one of you want to apply it to your context, then it's a very easy tool to use, basically. All right, so with that, we'll move on to Otieno, and I don't know, Lynn, whether you have anything to share as well? Okay, all right. And John, you tell us how much time we have left so that we can budget. Yeah. Oh, okay, all right. So Victor, you tell us how much time we have. Apparently you have the both. Yeah.
Okay, thank you very much. I think I had the option of maybe just giving one slide because everything else has been explained. So I can just give you the results for Nairobi. But I decided to spice it up a little bit so that I don't just stand here for 1 minute. So we are based at Parklands campus, and that's where the BAM is set up. And Abera, Kiros just mentioned the SOP on how to decide where to set up the monitor. So I'll just give you a quick overview of the way, the trends of PM2.5 in Nairobi between August 2019, or to be very specific, 22nd of August 2019 to 21st of August 2022. If you look at the monthly variation, we seem to have, you know, a dip in April, and then it starts rising during the cold, dry season, that is June through September. And this is the annual concentration. So you find that the peaks for Nairobi, okay, we have 2 peaks. There's a morning peak, which could be associated with traffic, and there's an evening peak, which is traffic and something else. So maybe that's something that we can discuss going into the future. And these are the day of week variation. And you can see the lower one is the Sunday. And you can see very well that on Sunday, of course, there's low traffic in the morning, but you still have the evening peak coming through on Sundays as well. So that source would be something of interest. Okay, we also have some spatial data from 10 schools. And if you look at that, you find the central business district, and then going to the northeast seem to have higher levels of PM2.5,
compared to the western and southern part of Nairobi. So, and this is basically just a sneak preview of the respiratory and cardiovascular ailments in Nairobi in 5 hospitals. And this is just for September 2019 to September 2020. So you see there's a time when the levels kind of went down. But our analysis the results I'm going to give you is not based on this. This is going to be used for a different analysis. So this is basically what we found in terms of the premature deaths attributable to exposure to air pollution per 100,000 exposed population. So if you look at the Kenyan regulation for ambient air quality tolerance is similar to interim target 1, which is 35 microgram per cubic meters. And if you apply it here, then there was no death attributable to air pollution. And you start getting death when you go to interim target 3 or 15 microgram per cubic meter. But that's also just based on the level of PM2, the average PM2.5 for those years. 17, 2019, it rose to 18 in 2020 and 19 in 2021. Now, so those are the attributable levels, and I just tried to extrapolate this to the population of Nairobi of approximately 4 million. I think this could vary, just as Abera was saying about Addis, it could vary between 4 and maybe 4.5 million or something. So this is essentially what we find. If we use interim target 3 through to the current WHO air quality guideline of 5 micrograms per cubic meter. So that's approximately what's happening in Nairobi situation. Thank you. Back to Kiros.
Yeah, so thanks. Just a word of caution, actually. So I think the calculations are made on, non-accidental deaths and, the adult population. So I think, when you extrapolate up, you also have to carry those elements into that so that the numbers mean something. But that's actually a very nice context. Lynn, anything to add? Or, yeah. In a way, we have 2 examples, and I think Kampala is going to be very similar. You just have to think about what the population is going to be for Kampala and what the average pollution levels are going to be. So, so I think this is basically what's going on in the GeoHealth Hub, and I think it gives you some concrete examples from the region in terms of how the health impact assessment could be made. And for policy, actually, they have, given all the assumptions, of course, being loyal to that, actually, they have some concrete value. Right? So I think, unless you want us to say anything more, I think we're done. Yeah, or if there are any questions.
I'm curious, Professor Tieno, if you've maybe, I know you're writing up this paper, if you've looked at maybe the purple areas in town and the different other monitors and see how comparable your data are. Thank you.
Yeah, thank you very much. Yeah, we've looked at the purple air data, and one of the reasons why we've not used it here is because it looks very different. If, for instance, we just look at the diurnal changes of PM2.5, for 3.5 years, our data shows very well that we have a peak in the morning at 7 and another peak at 8 p.m. with very little variation from day to day, every day. The purple air information we're getting is showing that the peak is at 3 a.m. So sort of a little bit different from what we have, and so we couldn't use it. And so what we were trying to do is to see whether how that compares with the low-cost sensors that we're having in the field, closer to where some of those air purples are. But we're using a reference monitor here, and a gold standard monitor. So we want to believe that the BAM is giving us the right information. Yeah. Yeah, do we have the U.S. Embassy data available? Yeah, yeah. Yeah, and we didn't even use our local, the local sensor for this analysis. We didn't use the spatial data. We only used the one data. But we take your suggestion of checking with the U.S. Embassy for their data for this purpose.
Yeah, I mean, I think your question is really important because this is a big uncertainty. I mean, they put the technical name, exposure misclassification, and the assumption that one monitor represents everybody is wrong, correct? And then the question is, how wrong is it? And does it make a difference? And in this context, there's many reasons to use the low-cost sensors. One is to identify those people that are really highly exposed. Back to my example of the whale and the tail, is to find the tail is an important issue. But I think that this exposure misclassification, which is just implicit, is there. And one way to think about it would be, well, you could do a sensitivity analysis and say, well, what if we take the U.S. Embassy data and get a lower bound maybe, and we take the monitor at Case Lab, and that's the upper bound, for example. So that's useful too. So there's information that's valuable in all this. Or you have 10 monitors in Pretoria, and you average them in some way spatially and come up with a better estimate. So the more monitors, the better. And then the question of how you use the purple layers.
Yeah, so wearing my biostatistician hat, actually, I think in terms of the context and the comparability of data is extremely important. So like, for instance, the US Embassy is a perfect example. They were actually sited at the embassy site to monitor the embassy population, and maybe it will capture the surrounding area. Even then, not so, because the embassy compound is very big, and the people living beside it actually are probably more exposed than the ones living inside. So your target population is very different. You're not talking about 4.8 million at that time, right? So the way you calculate the attributable does in how many people, is different. The school, the same thing. It's a very high income level population that goes to that school. So I think the context is extremely important, which is why I would believe the BAM for the GeoHealth, which was cited for the main reason to actually capture the city. The same goes for Nairobi. The purple layers might have purposes. The e-samplers have their own purposes. So, but the BAM, in addition to being a reference grade, monitor, it's also placed at the right level at the right time with all the misclassification probabilities still possible. We cannot get rid of them, but I think those contexts are extremely important so that we don't misinterpret the data. Yeah.
You could also use these modeled estimates from the satellite. There's a lot of people modeling, well, not a lot, but some people modeling the exposures for the whole planet. So, you can use those data too and make comparisons. I wonder, Alex, do you want to make some comments sort of about from your perspective? I think it would be useful, and talk sort of on the user side. Yeah. All right, we'll do the question, then we'll come back.
Thank you very much. Very good, interesting results. I'm just wondering what would be the, if we are at 35 with the PM2.5 and we move to 20, what would that mean for avoided deaths? What numbers are we talking about here probably?
0.
The difference?
We even did 25. We did the various interim targets. But remember that the PM2.5 on average in Nairobi is less than 20 microgram per cubic meter already. So if you're making it 20, then you make it above what is there. So yeah, perhaps so you need to be ambitious and and go much lower.
Okay.
Thank you. I was looking at the graphs that Prof was presenting, and while I'm aware that there was lockdown in Kenya, it was not very obvious on the graphs. So because there are declines from 2020, was it 2019? Okay, 2020, 21, and 22. Most countries had lockdowns in 2020 and 2021, but the declines even in 2022 actually compare with the declines you had during lockdown. So I was a bit confused. Maybe the site of the monitor is not affected by traffic or okay. Yeah, but I looked at that and I expected you to drop significantly when the cars were removed. But having said that, I think from the policy side, we have so many factors that affect us. It's not that we are not aware that actually evidence that such and an intervention works. Most times we are aware, and the evidence is usually there and very clear, even for the blind to see. But we most times have other several intervening factors. So you will see your attributable fractions and death attributable to air pollution, and you clearly see that it's a disaster that you need to handle. But if you to have that into to have the processes and interventions that should be related to reducing that, you have to look at the effect of your proposed interventions to the current interventions you are implementing. I know that, for instance, it's so easy in a developing country to implement an intervention that has multiple community benefits than one that just has one benefit. So if I'm to choose an intervention to reduce air quality, even if you have two interventions, for instance, to reduce air pollution, and I have two interventions, one very effective at reducing air pollution, but that's the main benefit it has, or the only benefit, versus another one that can reduce air pollution a bit, but is going to improve traffic flow, is going to improve transportation, and will make the community maybe develop. From the policy perspective and implementation, I will go with something that has more benefits than one that has significant benefit in one direction. So we often look at things like if the intervention, despite showing that it has highest benefits, is very acceptable to the community, because some things really work very well, like vaccines work very well, the science is there. But when you come to vaccinate people, they refuse. So what's the importance of bringing that intervention that is not acceptable? The others, of course, are things related to feasibility. When you do a policy and you have to eventually have it signed, let's say by the minister, he knows better. The first thing they will ask you is a certificate of financial implications. How much money do we need to implement this? And if it's long term, can we actually sustain it? So even if it is, as it has proved that it's 100% effective, as long as the financial implications to government are not sustainable, no one will take it up. So sometimes that's why we see a lot of evidence, but when we come to adoption and implementation, we take very many steps back, because you're going to do it 1 year, and in the next year when the budget framework paper is out, it has been knocked out because they know it can't work. This has happened to, Professor Lee knows that it has happened to when we are transitioning from, trying to transition from cash economy to electronic economy. And then eventually government was very ambitious, so they wanted tax on mobile money transactions. So they taxed them. Everyone moved away. So even the little tax that was coming out disappeared. And the government had to borrow to cover for the shortfall. The other one was importation of cars. You introduce 15 years, the cars become very expensive, people give up on cars. No one is buying a car, you're not getting any income. Even the best health health strategies and school that the government is supporting, it doesn't have income to support them. So yes, you are looking at the environment, you bring a policy to stop the cars from coming in, the old cars. The population rejects the new policy, it's not acceptable, they can't buy cars, you can't get money, you can't take care of school, you can't take care of anything. It's okay, you have controlled pollution. But there are other things that will kill people before pollution kills them. So those are the mechanics that put us in a corner, and despite the evidence, you just can't move. There are so many examples from previous scenarios where you ambitiously say we are not doing this, and then you disorganize the whole economy, the whole system. That's all I can comment on now. Thank you.
Okay. Thank you. I think that's really helpful. And in a way, in your comments, you've really sort of brought us from burden estimation, a health impact, or an impact assessment, which is looking at everything, because you change one thing, then there may be good things that happen and bad things that happen, and then you have to sort of piece this all, all together. I think maybe just a few more things. Let's question, and Victor, if I can go back to the old slides, that would be good.
Yeah, just a comment. Or two. I think I think what Alex has just explained is one of the things we are looking at in the scoping review, as in those strategies, and we looked at their core benefits and also looking at the unintended consequences within society, because we found that in some strategies that led to disadoption of the intervention. I think yesterday it was mentioned, like biogas. It has been it has been implemented, or we've tried to get traction from the 80s, but find in some communities, it's not been taken up quite at the speed that maybe people hoped for. So there are some challenges, around that. But that was not the main thing. That was, Prof, I think one of the things I picked up when you're talking about, the variance of readings between the reference monitors you're using and the local sensors. I think one of the opportunities we should take care of, or we should take advantage of, is to explore, because having dealt with different types of sensors, I know the headache that comes with calibration. Some are really affected by humidity, etc., and some measure quite accurately for certain months, and then after maybe 3 or 6 months, the readings just start going haphazard. So an opportunity there could be to try and look at the people using these local sensors, i.e. the purple airs, and try to analyze, periods where the data is close, and try to get like the information behind that. Or it could be maybe it has just been calibrated at that time, and one of the things you could come up with, maybe when should calibration happen, and when should we try to have a keen look at the low-cost sensors. So I think that is an opportunity if you work together with the people of the low-cost sensors, because I know the reference monitors are really closer to the true values. So you just have to find out how to work together with the people using the low-cost sensors.
I agree with you, and also just to let you know that we are happy to co-locate your local sensors so that you can standardize them, based on that. So if somebody is having local sensor before they set them up, it's quite okay for them to bring them to the reference sensor. Right now, we just purchased 11 Quantair monitors, and we are not setting them up in the field until we collocate all of them for a period of time, so that when they go to the field, we know what we are measuring. Thank you.
So I'm just to extend what Gabriel said. I'm impressed at this meeting. There are a lot of people working on the same problem who don't necessarily know each other, and that to have a platform for data sharing, or for saying, how do you access the BAM at the University of Nairobi for standardization, co-location exercises, because these monitors do perform differently, as you point out, and knowing what the differences are. There's a lot of, these low-cost sensors bring a lot of random noise too, so that, understanding that. But just an example of, I think, a useful outcome of this meeting would be to think about ways to connect people and to potentially have places that data could be shared, and you could say, well, these monitors have been cited here, these purple airs, and whatever other sensors have been cited here, and be able to bring the data together, compare, begin to get a denser picture across some of the cities in this region about what the air pollution is like. I think could be very, very valuable, and I'm sure everybody would be amenable to doing that. Just really have to have sort of the resources to do the exercise, because it would take somebody to create a platform, somebody to create the networking, but it's completely feasible. And I think, again, the kind of good outcome from the meeting that maybe we'll talk about when closing remarks are made. So, good comment. Yeah.
John, could you please explain exposure misclassification? It's come up a few times, and I think there may be people who are not sure what it means. Thanks.
Okay, so exposure misclassification means that you've said somebody's exposed to X, but it's not X, it's Y. Okay, and I think that's the easy way to say. Let me give you a great example. One exposure classification that really used to be easy, when people started studying smoking a long time ago, if you said to somebody, do you smoke? And if they smoke, they'd say yes. Now what is the answer? It's the socially acceptable norm. If somebody says, do you smoke? Then maybe you don't want to say I smoke. Or maybe you want to say, well, I used to, but I quit. But you really haven't quit. So that's, the issue. And so you say somebody's exposed to X, but they're really exposed to Y. The other question is, what is the difference between X and Y? And what generated it? So is it noise, like with our purple air samplers, perhaps? Or is there something more systematic? And I'll make it up. It's the it's the rainy season, and purple airs measure less than the reference monitor because of the humidity. I don't know if that's true or not. But so the question is, you say exposure is X, but it's really Y. And then why did that difference come about? And then the other question that Cardi was going to ask me next is, what difference does it make that you're using a wrong value? And that gets to be a little more complicated. And then you have to ask Kuros about that. And he'll run an exposure air model for you. Anyway, so that's the basic idea. And clearly, the sensor at Otieno's office is not the same as the exposure he has at the house where he's lived for 40 years. 40 years, that's amazing. It would never happen in the United States.
Yeah. I just have a question or a comment to those guys who are using reference monitors against low-cost monitors. So from our experience, even the reference monitors without maintenance, you get really weird data after some time. So the low-cost monitors have the same lifespan, not the same lifespan, but the same problems. So occasionally, over 3 months, if you do maintain your purple airs, you should be able to get almost the same data from the reference monitors. The trend will be almost the same, but there should be a difference in the readings. So the baseline of infrastructure and all these data quality is maintenance. Even the reference monitor, you struggle with it after a couple of times. So if it isn't maintained every 3 months or something like that, you really get, your approximation will be wrong over a certain month. So I'm just trying to make a case for low cost and reference working together because they all go through the same issues when it comes to data quality.
Do you want to comment? I mean, certainly we have experts here in trying to maintain the BAMs in the field. I mean, it's been a lot of effort, the maintenance.
Yeah, I think maintenance is a very important thing. Even for the reference monitors, you say you're talking about 3 months. For us, we do it every week. We have to clean it up because we find that after 2 weeks, there's a lot of PM10 and all that that's clogging the issue. So it can easily break down. So we clean it on a weekly basis to ensure that it's working at the optimal level. The other thing would be consistent power supply because that can break down the pumps after some time. So we also ensure that we try to modulate the blackouts. We have an inverter and batteries that have extra, power. So if the blackout happens, it can run for at least 2 hours without any problem. So when the power comes back, it continues. So all these are very important because one of the things in our SOP is the BAM measures, it captures information every minute and measures every hour of pollutants because it's real time. But if it measures for less than 18 hours, we don't use that as a daily value. So we we are very strict with the SOP. And perhaps if you talk to Abera or maybe with Lynn, you'll find that there are some days where they don't have data. It's not that the BAM did not capture data, but it captured less than 18 hours of data. So we need 24 hours for us to be confident with that data.
Okay, and I have one other point. I'm sure that the low-cost sensor technology is going to change quickly. I'm sure we'll get hopefully better and better and better technology. I mean, that's and hopefully more accurate. I mean, I will say this smartwatch. I did a study about 30 years ago where we spent $2,000, $3,000 on a watch to record 8 hours of heart rate data, and now you get that for, very, very, very little. Oh, you've got one. Okay.
My question was, I'm working with the local sensors, and it's quite interesting to learn about how the collocation goes about. I have a few questions. Maybe I can get in touch with you later. For me, I'm using Purple Air, and you've had an issue with Purple Air. So for me, in terms of local sensors, you've said you have new Quant AQ sensors that you're planning to collocate. Is it okay to collocate not old, but there's some local sensors that are not in the field, but they are somewhere, and then you're asked to use them later? Is it okay to use those local sensors and then collocate them, but they're not new, and then use them again?
I guess if you want to go and use them in the field, to measure PM 2.5, you need to standardize them, and we're very happy to host your local sensors. And the issue I mentioned with Purple Air was specifically the ones that are sending information to the website, the ones I was trying to get information from the website. I think there's one on Arguing Scott the Crowd and all that. Yeah, so that's what I mentioned. I don't mean that all Purple Airs like yours will be problematic, no.
No, I think the issue here is to be able to calibrate your local sensors. It's not that you go and throw them away. Just calibrate them so that you have you have collocated data as a reference, and you have your calibration factors. So
exactly.
You and you can do that maybe at the beginning of your study, 3 months after your study, and at the end of your study. So it will still be important as long as you've calibrated it.
Follow-up question, sorry. For collocation, the duration for the new local sensors and the old local sensors, is there a difference in how long you're supposed to collocate them?
Yeah, I don't.
I really can't tell, but like when we were having our e-samplers, which are the local sensors we have, we did it for 3 months, but I don't think you need to do it for 3 months. I think maybe 3 weeks, I think. I'm not sure.
I actually, does Pallavi have, okay, do you have an answer?
Maybe. So I think it really depends on where you're going to be installing the monitors, and also how long you have already been using them, especially if they're old, because there's definitely a shelf life for the sensors in the low-cost monitors. So there will be a while where you can, bring it back to a reference grade station, redo the calibration, reinstall it, but then you have to be careful about what those locations are, because there will come a time when the sensor will not, even with the calibration, you will not really be able to use it anymore. So there is a definite shelf life, and in the last 6 months there have actually been a couple of papers that have looked at that exact question, like how would the life cycle of a sensor work and how would you use it under different conditions. So that would be a good place to start, to think about new versus old, how many times can you go through that cycle. I think for different people have used very different approaches, so I would say a few weeks is generally important. You should do it. And then especially if you're planning very different seasons, and you know that the levels are going to be different, and temperature, relative humidity, patterns are going to be different, you probably want to do collocations that are representative of both of those, but you probably don't need months and months of collocation because you want to get your instrument out to the field.
I think the other thing you could do is ask Kiros to ask a graduate student to work out how long you would want to, how much data you actually need to sort of get different levels of certainty about how comparable or non-comparable the two sets of monitors are. I think that's something that could be worked out. Let me do a time check here, because I think we probably have some wrap-up things and comments to make. More
No.
well, so why don't we keep with questions, and and we'll skip any more slides. But more
Sorry,
questions.
I
more
have the mic again. So I think this points just to how much we don't know each other. And when we talk about these purple airs and, maybe not hating the purple air, but understanding whose monitor is doing what where. So like the one you said in Agwings Codec is my purple air. So it's just interesting how we don't know each other and maybe how we could collaborate a bit more
For
and
sure.
know what it is for. Yeah, so that's interesting. And I think the more we talk to each other, the better we'll understand what the purpose is for this was. And when maybe a study ended or is no longer being used, there's a lot of information perhaps we aren't sharing with each other. So it's really nice that we know each other now. Thank you.
Yeah, and I think the only other point I will add here is that there's always going to be this discussion about how good is the low-cost sensor and what can I use it for. But it is very important to remember that the low-cost sensors are extremely valuable for a variety of purposes, including public engagement, citizen awareness. And in some cases, these low-cost sensors may be installed in someone's home, so the pattern is not going to be representative of everything. It's going to be representative of what's happening in that very small location. That doesn't mean that sensor is necessarily wrong. It just means we need more information. So I would just, again, emphasize that low-cost sensors have a very useful role to play in advocacy, communication, public engagement and awareness, and they have a very relevant role also in research. We just need to fine-tune, Diana, as you're saying, how and where we are using them and what the purpose is and how we can use the data. So just clarifying that.
Great. Why don't we, if there are other questions just about what we've been talking about, the burden impact assessment and all the things, we've covered a lot of territory. And I think maybe we're, done. So just you have to remember what all the things you're going to remember. Okay, so the attributable risk formula, you're going to remember P and RR and the formula, excess risk over total risk, and it goes from 0 to 100%. Attributable versus avoidable, and our favorite, the counterfactual. Okay. That's great. And then, I think this has been a good introduction. And then you can see that with the GBD and some of these other things, there's a lot of complex calculations. But the AirQ Plus is a simple, straightforward tool that you can use. And thanks to everybody for sharing experiences. So with that, Victor, are you taking over or who is?
No, I just had a question on this one for Kiros and the team. So we have different cities represented here. In Nairobi, we have Nairobi as a county. We have 17 sub-counties. 17 sub-counties. Uganda has Kampala as a city, 5 districts. Addis has Addis as a city, 200 waredas, 200 and something. So then the question now becomes, I'll use a Kenya example. We have one BAM in Parklands. Which sub-county is that? Parklands, Westland sub-county. Same for any other city. So you plug in your air pollution data. You want to use Parklands County to represent Nairobi. That's your first uncertainty. That's what the analysis is at the moment. That site is representative of the whole of Nairobi. I'm right. So would there be any benefit in him to reduce that uncertainty to come down to sub-county level? It will be hard to get, it may be easier to get mortality data. It may be harder to get Margaret will tell us population data at sub-county level. I know for Addis it's possible to get Wareda level population data. So again, I guess my question is, because then the messaging becomes a bit difficult. 17 is 17, Nairobi 7. What does? So I guess my question is, would it be easier if you go down? How far down can you go?
Sorry, maybe before Kiros answers that question, I just need to put a caveat. You know, those are political administrative areas. Yeah, those sub-counties of 17 you're talking about. But we were looking at planning zones for Nairobi that were made before they went into this political, those sub-counties. And we divided Nairobi into 8 planning zones. Actually, we didn't. That was already the plan for Nairobi. Nairobi had 8 planning zones. And so if you look at the e-samplers, we've distributed them within those 8 planning zones. So I think we need to have that as a caveat. And Kiros, this sub-county 17, those are political.
Right.
Not
yeah. So I think a couple of things. Like conceptually, the numbers have to align, right? So first of all, what's your purpose? Are you trying to have health impact assessment for Nairobi as a whole, or for some specific location? Maybe it could be, high biomass area or, industrial area or something. Then the population size becomes very different, right? Because the target population has to be well defined, right? So based on that, if you're talking about a subsidy defined in some preconceived way, then having a monitor that's representative of that area becomes important. It could be one of the e-samplers, or it could be something else. But the number that you get on exposure also has to be reliable. Then the issue of measurement error, noise, all these issues come into play in terms of purple air versus reference. If you have a BAM, let's say 10 BAMs, and then you can run them 1 or 2 years in some location, then you have reference grade exposure, right? So you have less misclassification. But remember, the BAM at the University of Nairobi, the site was actually used not because Otieno is there. It's actually used, chosen after following the SOP. Where is, the location in Nairobi that's secure, that probably secondary, but also potentially representative of the city. It's not too close to point sources. It has some distance from major roads. It's not heavily kind of affected by something that's not representative of the entire of Nairobi. But at the end of the day, as John said, it's going to be a misclassified exposure. If I live in Otieno's house versus, some other more polluted house or less polluted house, it's not going to be representing me. But on average, we are, assuming that, it has some representative values. So whatever number you get at, first of all, is what the target population is, what your question is, and you always have to get it, with a grain of salt, because it's not going to be exact. It's population aggregate level statement that you're making.
I mean, one point is that this is where the low-cost sensors could be helpful to define just how much misclassification there is. And you might decide that you can't represent a complicated geography with one monitor. And say there's hills. Yeah. Addis has hills. I mean, you can get into complicated territories where you say, well, we have to have 5 monitors and not 1 if we really want to represent population exposure. And again, the low-cost sensors could be helpful for that purpose. Even if they're noisy, they're still going to give you useful, useful information. So let's see. I think. So I turn back to you, Paula.
Yeah. And I think, John, when you're back next time, we're going to be asking all these star pupils difficult questions. Now that we know everything about health impact assessment, or qualifier about burden assessment, I think I will just take a couple of minutes before I turn it back to Victor. I was just going back to what we said in the workshop, background document, what we wanted to do in these 2.5 days, which was to review the available evidence and information, to find how it is interlinked to policy already or not, and then also to find strategies that we can all work on together to work towards better air quality, to work towards better public health. And I think as I'm thinking back to the last 2.5 days, We have done a lot of that. I think a lot of ideas came up, a lot of connections came up, people who didn't know each other, collaborations we didn't know we could have. And as we also said yesterday, we have been very carefully documenting all of this, so it's not just what we talked about. We will write all of it up so we can follow up on different people that we want to connect to. And if there are any others who were not here in this room, who should be in a future room, you know, when we have similar conversations, then let's figure out who those are as well. I think we need more Dianas in the room who are asking all the, you know, difficult but important questions. We need the Jerrys in the room who can tell us this is what the policy can do, cannot do, and this is how we can make it work. We need the Margarets and the Celelas in the room who can tell us what they need, and the Alexes who give us a reality check. It's not just air pollution. I'm trying to deal with a lot of different things. And then, of course, we need the scientists who can, you know, continue to do more research. So thank you so much for being here for the last 2.5 days. And we also said in the workshop background documents that you know, the conversations and the discussions here will help inform what we can do in this region to help all of you to take this work forward. And I think there are many really good ideas that came up in the discussions. There may be others that are forming in your head as we spoke about those, so let's keep that discussion going. What we will try to do from our side is, you know, write up some of this. There's definitely things that as an organization we do. There are things that we do not necessarily do. That's not in our scope. But what we would see as some immediate next steps that are tangible perhaps is look into that question of can we do something to summarize the health evidence a little bit more? Because I think that is a question that was coming up from many different conversations. So if anyone has ideas on how to do it, who should be involved, again, people in the room, outside the room, we would very much want to hear that. I think there's already existing information and data that we can start to see how that applies to certain policies, how we can help, you know, what is being done to think through some of the decisions that are being made. And then we are a institute that funds research, so I think that's definitely on our radar. Whether that happens in 6 months or 8 months is the bigger question, and what scale it will be is also a question, but that's something we want to figure out with all of you. So I don't want us leaving this room and thinking this was just another workshop. We will request for your engagement over the longer period of time so we can figure this out together and do things collaboratively, building on each other's work. But thank you very, very much. And I want to thank a few people in particular just once again. John being the first one, who's been our teacher and leader and the grayest hair in the room, as he proclaimed himself. And also the one that gave us the lesson that you can always call on your students even 30 years later. So you better be ready. I think there are also some people in the room here who contributed in many ways to the agenda for the workshop and the people who came here. So all of our co-organizers, Stockholm Environment Institute, World Resources Institute, AirQuo, GeoHealth Hub, thank you very much for very patiently working with us on this over the last few months. And I think I will be remiss if I don't thank Victor, who really was the person that made all of us come together in this room, sit here for 2.5 days, and just focus on this topic. So thank you very, very much, Victor. And I think, as Alex said, everything always comes back to funding. So I do want to thank our funders, Clean Air Fund. They allowed us to do all of this, to bring all of us together, and hopefully we can continue to talk more and do more in the future. So Victor, any final words of wisdom?
Well, not really. In government, when the minister has spoken, the only thing left to do is to close the meeting, right? Anyway, I'll just say very briefly, I think I have all of these people on WhatsApp. I can get to anyone. If not, we need to talk. I'll be bugging you, you'll be bugging me. I think the idea for us is we are here to sort of start engaging with you, try and figure out this thing together, and try and see how we can improve on what's being done already. We need to have conversations with NEMA on air quality standards. We need to have conversations with ECI, GeoHealth Hub, and many other players in the room, AirCo, etc. I really can't, mention all of you. So thank you very much for honoring the invitation. In our culture, you can invite a guest and they refuse to show up. So when you show up, we have to say thank you. So thank you so much. I don't know if I should call Raf to close for us, just as the host, as Nairobi County. Other than this, I think we are done for the training. I don't know what's the best way to get feedback on the training. What do you think you need to know next? We know avoidable, attributable, counterfactual. And when you think is a reasonable, time scale for us to repeat that, take that conversation to the next level. But I'll talk to you all and get that from you. So, Raf?
It was an ambush. Mine is just to say thank you. Thank you so very much. On behalf of the County of Nairobi, we say asanteni sana. Let's say thank you very much. So those who are traveling far and wide, may you have safe journey masses. And let's engage. Let's be together, let's engage. Let's make things work. Asanteni sana. God bless.
So final announcement, I think our lunch will be served just outside. So we are having a different lunch experience every day. So enjoy. There are no demonstrations today, so no chance of tear gas. No. You'll see me separately for that.